personalities and the constant adaptation that he demonstrated from an early age. Son of Mike and Eleanor Cleary, Sean lived a very international life. By the time he finished high school, he had attended school in 6 different countries. He started preschool as a toddler in Cincinnati, Ohio. He then attended kindergarten and first grade in Toronto, Canada. His second and third years were in Vienna, Austria, at an international school. Then, the next 3 years were spent in Newcastle, in the UK, at the local school. Remember, John? His final 2 years of primary school were in Brussels, Belgium, at an international school. Then, he returned to Toronto for 4 years before finishing his secondary education with a year in Neuchâtel, Switzerland. Along the way, he became pretty conversant in German and French. Sean is a great sportsman, although he was never able to focus on a particular sport due to the many moves in his youth. He is a great skier on snow and water. I was also able to rescue this sentence. Even today, he's one of the best water skiers you'll never ever see. The fact that this father said it doesn't take away from his fairness and realism. Sean is also passionate about fitness. He works out regularly, cycling about 60 kilometers on weekend, and is a good open water swimmer. Last but not least, he's an excellent ice hockey player. Since returning to Toronto, he has joined a men's hockey team and plays every week, surgeries permitting. Sean is a super fan of the Toronto Maple Leaf, but since this is a happy occasion, the less we talk about it, the better. Seriously speaking, this year the team is 5th. Not bad, Sean. I don't know about you, but between so much energy and travel, I need a break. Two stories from his early years show us the Sean we know today. First, when Sean was 3 years old, his father had to go on the roof of the house to fix some tiles. He thought Sean was in the house with his mother, but a few minutes after he started working, he turned around and there was Sean standing on the roof saying, "Can I help you, Daddy?" It looked like the determination he showed today is not new. The other is when Sean was about 6 years old and they were living in Vienna and the parents had to take the car for a service. Given their limited knowledge of German at the time, they decided to take Sean, as he had acquired, as children often do, some conversational German. Although he didn't know any vocabulary related to the car part or maintenance, etc. He was able to translate what the service manager was trained to tell the parents. After about 3 minutes, he stopped, looked at the parent, and realized what was required. They were surprised when he spoke directly to the service manager in fluent German and explained what was needed, which resulted in the car being successfully repaired. This is the beautiful family: his parents, Mike and Eleanor, his sister, Stephanie and Lisa, his wife, Janice, and his son, Owen and Christian. Sorry, I should not forget Will, the other member of the Cleary family. Moving forward in time, Shan studied medicine, then surgery, and during his surgical residency, he took a 2-year sabbatical to work with Professor Stephen Gallinger to conduct a study on mutation in colorectal cancer as part of his first master degrees. With Steve, one of his mentors, they clearly had good time to during those years of study and research. Sean trained in HPV surgery with his great mentor, Professor Paul Gray here. Here, a couple of photos from those years. To define Sean, what is taught from Paul? I was always about Sean. First, his steadfast commitment to the discipline of HPV oncology in an environment where transplantation had very strong institutional support. His clinical and academic collaboration with our GI medical oncologists set the standard and pathways for what became our highly integrated management of complex HPV tumor. And the second sentence, his commitment to the well-being of his family. I was aware that the personal priorities of the next generation surgeons were branching away from those of us baby boomers, and I was most impressed by Sean's consideration for his wife Janice and his sons, while maintaining a very busy HPV surgical practice and academic career. To end this brief tour, I would like to share you two aspects of Sean's great work for our society. Firstly, his fantastic work in the outreach mission, which led him to win the Gazi Award. Just as an example, his 2014 mission to Honduras with Elijah Dixon, Hoover, and the local team. And for example, in the same country in 2017 with Kuyen Chu, among others. The other aspect is his great dedication to leadership position in our society. It was been a pleasure and an honor to work with him over the years. I have no doubt that I speak for the officer, all the council, of course, and Jill and Margie, and said, thank you, Sean. I would like to end with a question I ask myself every year, Sean. How come the years go by and you always look like 20 years old? With you, our president, Dr. Sean Clary.
I assure you I'm not that good a water skier. Mariano, thank you so much for that extremely kind introduction. It really is a very touching and humbling and very generous. So, thank you all for coming this morning. I want to begin by saying to all of you, the members, the leaders, and the staff of the Americas Hepatobiliary Association, what an incredible and tremendous honor it has been to serve as president of this incredible association for the last year. I'm truly humbled and grateful for this opportunity, which has no doubt been one of the highlights of my career. To me, the opportunity to lead an association filled with such incredible, passionate, and talented members has been a chance to encourage and facilitate, or simply stay out of the way, while our members do amazing things. Probably the hardest thing about being president is just this: getting up and standing up in front of all of you, trying to say something intelligent. Over the years, I think I've attended 16 presidential addresses, which have sought to inspire us in various aspects of our clinical and academic endeavors. Some of them tackled key issues facing our specialty, such as Ted Pappas's address on the training and surgeon supply in the United States. or Mark Callery's expanding the vision of the association into Central and South America. The push by Dr. Callery to go global on that hazy morning in Las Vegas, and I'm not talking about the weather, was a huge step forward in inclusivity for our organization and enhancing and diversifying the membership and increasing the impact of the AHPBA for surgeons and patients across the Americas. These meetings and these addresses were important turning points in our organization, and I tried to reflect on preparing for this today. In no way did I think I could make such a monumental impact as some of those speeches, but hopefully in the next few minutes, we can all reflect on the vision of our association in a way that hopefully does not achieve the title of most boring presidential address ever. I do, however, have people prepared in the audience to pull the fire alarm if it does get to that point. Good job, guys, on the test run. I do appreciate it. While I'm not terribly introspective by nature, I tried to reflect on what brings us here together today. What takes us away from our jobs or our families to talk about liver, biliary, and pancreas surgery? We come together simply because of our passion for our amazing specialty and to share our perspectives and experiences. Perspectives and experiences that are shaped by our training, the environment that we work in, and to a certain extent, the increasingly diverse paths we've all taken that have brought us here to this place here today. Certainly, we have our own stories of what brought us into this field. For me, it was as a medical student in London, Ontario, the other London, seeing a liver transplant and then being told late at night to go home by my senior resident and read everything I could about a Whipple procedure, because tomorrow we were doing one and it might be the only one I ever see. It wasn't just a nostalgic trip into my past, but it was a recollection and reconnection with that sense of awe that we all had when we were first exposed to this terrific specialty. It made me think about what an incredible privilege it is to be able to practice in this field. On my second tangential thought went back to my first day at Mayo Clinic. They have you attend an orientation, some people call it a propaganda session, which immerses you in the history of the institution. And they emphasized William Mayo's 1910 commencement address to Rush Medical College, in which he stated, "The best interests of the patient are the only interests to be considered. And in order that the sick may have benefit of advancing knowledge, a union of forces must be necessary." I think that really describes what we do. Now, this motto is a lot for us in the 21st century to say, so it gets simplified to the needs of the patient come first, which is one of the guiding principles at Mayo Clinic. At first, this sounds like a Nike just do it slogan or pick your other favorite marketing slogan. But the longer I heard it and the more often I heard it, and I heard it a lot, it actually started to have a very grounding effect on me, reminding us why we do what we do. All the research, the modulation of the serine phosphorylases, our analysis of margins, recurrence, and conversion rates that we are going to discuss this week and have done in every meeting in the past and going forward. It's all for the betterment of patients. Testimonials like Melinda Bikini's a couple years ago were so inspiring, but they have to continue to ground us. This led me deeper into realizing that the privilege wasn't fully granted to me by my training or by my credentialing, but this privilege was granted to me by the patients who came seeking help for some of the most complex and fatal diseases. And then I realized I probably don't think about this aspect enough, even though it's so core and so central to what we do. It's about the patients. And it's these kind of experiences, the thrill of taking out a large tumor on the right-hand side, the tumors always get bigger and the resections always get more complicated. But it's the interaction with patients that really continues to drive me. This patient gladly shared this photo. She did want everybody to know that this was post-op day one, and she usually looks better. So in a very real sense, we gather together at this meeting and in this association to share our knowledge and to collaborate to improve the outcomes of the lives of our patients. This focus is on patients not only evident in our history and what we do on a daily basis, but in our mission statement, advancing HPB care to improve patients' lives. And so the future of the AHPBA must continue to be focused on enhancing care and outcomes for our patients. The AHPBA started 33 years ago as a liver and pancreas surgery society that sought to define itself and differentiate itself from general surgery as we recognize that expertise, focus, and to a certain extent, repetition were important in improving outcomes. I'd like to suggest that that process has been incredibly successful, but far from complete. Over the years, we've seen tremendous progress in increasing the safety of liver and pancreas surgery. An operative mortality and the risks of operations was probably the first thing that we addressed. I think it's easy to forget that 4 out of the first 5 liver transplants Dr. Starzl did not survive the operation. The operative mortality rates for Klatskin tumors were 28%, if you listen to Dr. Blumgart, 11% for colorectal liver metastasis, if you listen to Dr. Marty Adson. And so it was really a seminal moment for our specialty in this region that 33 years ago, Michael Henderson, Bill Myers, Ron Mayer, Henry Pitt, and Ted Pappas founded the AHPBA as an opportunity for collaborative work in answering some of the important questions, a focal point for young people developing skills in this field, and a forum for the needs of this emerging specialty. And I think those words ring so true today as they did 33 years ago. It was clear that the intention of those early HPB surgeons was to recognize specialization, unique skills, and focus were required in our field and sought to differentiate it from the broader context of general surgery. I was extremely fortunate enough early in my surgical career to work under Dr. Bernard Langer. I was even more privileged and honored this year to be granted the chair that bears his name. Dr. Langer, like his contemporaries, Dr. Pitts, Starzl, Marty Adson, Les Blumgart, Henri Bismuth, and others, worked to define and promote hepatobiliary and pancreatic surgery as well as transplantation across the globe, not just as a subset of surgery, but a unique specialty requiring dedication, concentration, and focus. Anyone who trained with Dr. Langer, and there are many of us here today, remember what an intimidating presence he was, not only in his manner, but also his intellect, and that he always seemed to be looking forward and ahead of his time. While he made many incredible contributions to technical surgery, he always seemed, his later part of his career was focused on improving the quality of cancer surgery, particularly in his home province of Ontario. Inspired by the work of Birkmeyer, Dr. Langer looked at the emerging concept of specialization and outcomes and showed that in Ontario, 57% of liver and pancreas surgery in the province was specific focus and specialized teams of surgeons and that there were substantial differences in the outcomes between operations done at these centers and those done in other hospitals. Now, before I should go further, I should explain and clarify and contradict Fox News a little bit about the Canadian healthcare system. The Canadian system is essentially a single insurance company, the government, where all citizens are insured and all citizens have equal coverage. Hospitals themselves are autonomous and nonprofit, and surgeons are largely an individual practice. So it is a little bit like herding cats at times. But Langer led a systematic review, again ahead of his time, to review the evidence and was able to define a series of standards that should be used to define a center of excellence for HPB surgery, specifying a group of fellowship-trained surgeons working within a dedicated program, and probably most importantly, the essential supports and requirements for intensive care, interventional radiology, and finally, volume outcome targets. Now, the idea of a volume outcome relationship was becoming well-defined at this time. It certainly wasn't new and really had been started in the 1970s by Luft when he described the relationship between operative volumes and mortality. It was really Birkmeyer and the Leapfrog group that really brought this concept to maturity with their work in the early 2000s that showed a greater than 4-fold difference in operative mortality between low and high volume hospitals for pancreatectomy. Now, Dr. Langer was able to enforce these guidelines and get the insurance company, the government, on board so that HPB surgery would be only reimbursed in centers that met these standards for an HPB center. And as you can imagine, this changed behavior very, very quickly. And the number of hospitals that did HPB surgery in the province of Ontario went from 68 to 10 in less than 10 years. Now that's 10 centers for over 14 million people with specified volume targets. With this implementation of standards and the associated financial sticks, the number of cases being done in specialized centers went from 57% to over 95% in 10 years, and the mortality for pancreas resection went from 12% to 3.9%. Now, We have to acknowledge that other improvements in our specialty were occurring at the time, in particularly critical care and anesthesia and the emergency of interventional radiology and, of course, surgical skill. But I don't think we can underestimate or underemphasize the impact of reducing operative mortality by 67% in such a relatively short period of time, and the significant impact such a dramatic regionalization had on outcomes. Think of the things we're willing to do in surgery to improve the patient's chances of a 5-year survival by increasing it by single-digit percentages. Putting that in the larger context, in Ontario, which has about 1,200 pancreatic resections, this reduction in mortality is saving 100 lives a year. Now, as everyone knows, the volume-outcome relationship isn't a statistical anomaly, and it's been replicated over and over again in Europe, Asia, the Americas, and basically every region and database in the United States. But as we come to explore this further, like so many things in life, the relationship between volume and outcome becomes more and more complicated. While we'd like to think that we as surgeons, our skills, our intellect on patients, it turns out that hospital volume has a stronger relationship than surgical volume, and that the volume of other complex surgical procedures like transplant, cardiac, esophagectomy, vascular surgery, and even colon surgery can influence the outcome for HPB surgeries, regardless of the volume of HPB procedures done at that site. So it must be acknowledged that we as surgeons do not operate in a vacuum, but it is much the teams around us that make a difference. The rate of complications between high and low volume centers accounts for a portion, but not all of the outcome differences. But it's the ability to promptly recognize and treat complications and support patients that likely contributes to a significant portion of the differences in outcomes. And as we all know, this has come to be known as the failure to rescue phenomenon. And I think now we're starting to even better describe and interrogate the differences in patient populations and characteristics in terms of race, socioeconomic status, comorbidities, insurance status, as well as many of the other so important social determinants of health that overlay the complex relationship between us as surgeons, our hospitals, and our patients. And mentioned, this has been a widely recognized phenomenon for 20 or more years. And while many countries have responded to this data with a push towards regionalization in centers, this is largely because those countries, the health insurance provider, which is often the government, has insisted upon it. However, the story here in the United States has been a little slower. There have been significant trends towards centralization and regionalization, but still, even the most recent articles show that 30 to 40% of patients undergoing liver and pancreas surgery are having surgery at a low-volume hospital, which is variably defined, but generally performing less than 5 cases per year. As mentioned, there's likely a lot of reasons for this, including insurance status, travel distance, and all those other socioeconomic reasons that we talked about, reluctance to travel. But as these barriers seem surmountable, Berkmeyer was able to show that 25% of patients that had pancreatectomy at a low-volume hospital actually traveled past a high-volume hospital to have their surgery. Why insurance companies have not insisted on the standards implementation is a bit of a mystery to me. I'm told similar challenges in specialization and regionalization persist across the Americas. And one of the things I've noticed personally in the United States when seeing patients who were being treated by surgeons and hospitals was that sometimes they're clearly outside of their abilities, training, and resources, often with negative consequences. These challenges arise not, in my opinion, due to deficits in technique or skill, but can be lapses in judgment, failure or delay in recognizing complications, and often a reluctance by a surgeon or an institution to admit that they were beyond their capabilities. High-volume centers are not immune from these problems, but the hope was as we build capacity and we build highly functioning multidisciplinary teams that we can at least somewhat reduce or mitigate this. As Carol Ann Moulton and others have shown, our surgical culture of pride, self-professed excellence, and self-reliance, as well as the financial and institutional performance pressures that we place on ourselves and our institutions place on us, can be a dangerous thing for our patients, but also for ourselves. Surgery is humbling. We need to park our pride and our ego because sometimes, always, the needs of the patient come first. But more relevant to the AHPBA is how organizations like this one can enhance our ability to collaborate, to communicate, to stay up to date on all the latest therapies, decision-making, and technology, and how we can use that tremendous resource and power to improve the care of patients across the Americas, perhaps even flatten the volume outcome curve. Now, you're probably expecting me, as a person who's worked at 2 ivory tower institutions, to make a personal plea for ultra-regionalization and specialization. I usually hate to disappoint people, but I will, because I'm not naive enough to think that it's feasible, nor is it probably the right thing to do for our profession. And sure, you're probably wondering why I would offer a relatively remedial and simplistic summary of quality outcomes and centralization to a group of surgeons who, quite frankly, almost all practice at high volume institutions. This is what my Roman Catholic father would have referred to as preaching to the choir. However, I think we need to acknowledge the incredible contributions, the accomplishment in its first of this association, its first 33 years, and look forward in the future how we can address these disparities in our specialty. This association has been a significant contributor to establishing HPB as a specialty, as well as establishing rigorous and demanding criteria for our fellowship training. Our meeting and our organization continue to be important vehicles for collaboration and the dissemination of knowledge and experience. Thanks to the efforts of people like Elijah Dixon, Mike D'Angelica, Tim Pollock, and others, we're now becoming a contributor to cooperative clinical trials in our specialty. The broadening of our society into Latin America and Canada has expanded the scope of our association, as well as the diversity of thought. We need to continue to collaborate and invite our colleagues from Europe, Asia, Australasia, and even Africa to expand our horizons and learn at a global level. And we must continue to do all of these things and continue to do them with passion and conviction. The AHPBA is incredibly strong, and it's due to the strength of its membership and has significant resources. Every organization must continue to evolve, and we should always be reevaluating our mandates. Just like a clinical or scientific problem, we always identify gaps and needs, promote hypotheses, and address the solutions. Our mission has always been focused on improving outcomes for patients, so nothing's really revolutionary here. But to me, the challenges we need to address is enhancing the outcome and safety of HPB surgery for all patients at a population level by enhancing inclusivity and capacity beyond our traditional membership and beyond our traditional constituency. We need to try and flatten the volume outcome curve so that more patients can benefit from high-level HPB care. I'd like to suggest humbly 4 areas for your consideration as we look to the future of the AHPBA. First is what I'd like to humbly propose is that if our organization, the AHPBA, is truly committed to improving the outlook for patients with HPB benign malignant diseases, we must continue to push ourselves, as Chuck Vollmer referred to continue to get better. We must be more inclusive and comprehensive in our approach to this problem in looking outside of our traditional membership and, quite frankly, outside of this room. We can make significant impacts on things at a national level by reaching out and being more accessible, building bridges with surgeons who practice in middle volume institutions that statistically are treating about 30% of our patients nationally. The gap between those institutions, the high and medium volumes, is not insurmountable, and narrowing that gap could reduce operative mortality by 50% in the procedures that we practice. We have seen through members of our association, including the originals, Paul Hansen and Margot Shoup, how high-quality, innovative care can be delivered outside of a university-affiliated or high-volume environment in smaller cancer centers and private practice settings. This is also an accessible population of surgeons. As Rohan Jayaraj has shown us, many of our graduates of our fellowship programs, whether it's HPB, surgical oncology, or transplant, are populating and getting jobs in these medium volume institutions. Trainees who want to practice HPB compared with the number of jobs available. We have to continue to support not only these new graduates, but established surgeons in building programs and capacity at their institutions and help them advocate with their administration rather than being forced simply to deliver the patient volumes their institutions want or expect. But as we know, training is not enough, and we need to continue to collaborate and involve surgeons practicing HPB surgery in all settings. We know that excellent outcomes are possible, particularly if those institutions are already practicing complex GI surgery, surgical oncology, transplant, or even cardiac surgery. We need to address our collaboration with surgical oncology and transplant training programs for the betterment of the specialty, but more importantly, for the betterment of our patients, by raising the bar and finding ways to address gaps while maintaining high standards. The AHPBA is uniquely positioned to fill those gaps by helping benign disease for oncology trainees and malignant disease for those who practice transplantation. These challenges are paramount with the establishment of our transplant oncology discipline, as Majella Doyle outlined last year, as well as the challenges presented by the evolution of technology in our field that is everywhere at this meeting and everywhere in the exhibit hall. This will continue to challenge us, and while we acknowledge that there may be differing priorities or drivers or even competing meetings for those in mixed practices or private practice that may not prioritize conference travel, we need to be sure that our AHPBA meeting continues to be highly valuable, relevant, and welcoming. Other organizations may seem to appeal at present to this group, but we can change that by becoming more accessible and relevant. We have had a small but passionate group of surgeons who deliver excellent high-quality care in specialized teams to HPV patients in private practice and smaller cancer centers. The AHPBA has a tremendous amount to offer. We need them to continue to play a larger role and have a bigger voice in this association so that HPV surgeons outside of the traditional blue blood, ultra-high volume centers feel welcome and that their insights and perspectives are valued. My second proposal is that we need to be very deliberate and strategic in continuing medical education and skills development, not only during fellowship, but after fellowship, as the new technology and science changes our specialty seemingly on a daily basis. We've had tremendous success in this area, fellowship training, but with adjuncts like ultrasound and ablation courses led by Ellen Hagopian and Mariano Jimenez. Training is not enough, and we've all made a commitment to lifelong learning. We need to look beyond the pearls and wisdom that we impart in fellowship. In its developmental years, our specialty was front and center in the role of laparoscopic cholecystectomy that improved patient lives, but we learned a lot about introducing new procedures and technologies as the epidemic of bile duct injuries followed. We could argue about the mixed impact that we had on the evolution of laparoscopic liver and pancreas resection, and some of our fellowship programs still struggle to give our fellows an adequate experience in MIS-HPB. So we still struggle with these gaps in training for new and established surgeons that, for the most part to this point, have been filled by industry and emerging associations. The area of robotic surgery, as we've seen this week, isn't coming, it's here. One safe bet for the future is the continuing convergence of minimally invasive surgery and interventional radiology, and there's no better example of this than our next president, Mariano Jimenez. I would suggest that we as a society continue to take a very active role in the evaluation and introduction of new technology and technologies in our specialty with very direct involvement in not only establishing standards, but in developing, delivering education, dissemination, and implementation strategies. Third, as we've seen, it's the entire multidisciplinary team that truly impacts our HPV patients. I've been so grateful over the years to work with so many fantastic people who, in all honesty, probably contributed more to the success of my patients than I ever did. I'm so fortunate to have some of those people here today. And as an association, we have to make progress in incorporating our advanced practice practitioners into the meeting and into our association. If we really want to have an impact, we need to double down on our efforts to welcome APPs, nurses, and really anyone who touches the lives of our patients along the surgical journey. And yes, maybe even we might have to invite the odd anesthetist or interventional radiologist. Building capacity in all centers will continue to improve the lives of our HPV patients. Finally, when we say we want to improve the outcome of our patients, we have to move improving all patients. Our advocacy efforts continue to address the gender, identity, racial orientation, and socioeconomic barriers to obtaining high-quality HPV care. This is a really big problem and a really huge topic that may seem out of the scope of this association. It's certainly a daunting task. But we know many of our patients cannot access or don't feel welcomed at our traditional centers of excellence. So we need to not only enhance our inclusivity of our association, but build capacity with more surgeons and more centers in diverse communities. So in that way, we can have some impact. Almost as importantly, we need to continue to work to identify and remove the barriers to entry to this tremendous profession so we can truly have the best and the brightest, defined only by their intelligence, their talent, and the content of their character. When I first came to this meeting 15 years ago, you could count the number of female surgeons in attendance probably on one hand. Shout out to Margot Shoup and Rebecca Minter and Ellen and many of us. But look at us now. We've made tremendous progress in this area, but let's not be satisfied with this. There's a lot of work to do to make sure that our specialty looks like and thinks like the communities that we serve. So in conclusion, if we truly want to improve the lives of our patients, then we as an organization must continue to focus on the needs of not just ourselves in our professional and academic endeavors, but must focus on the needs of our patients and all patients. We must maintain an expanded scope of our vision and be more inclusive and accessible so that we can continue to collaborate and improve the outcomes for all patients. Finally, I hope you can allow me a minute of indulgences to express my gratitude to the many people who have helped me in my life and my career. First, I think we all need to thank Margie, Jill, and the entire team at LP. It's impossible to understate the impact these two and their team have on the health, vitality, and the success of this organization. They make all of this look easy, which is really difficult when you're dealing with someone like me. It's an amazing amount of work, and I want everyone, please, can you all give them a hand? They're back there hiding. A huge thank you and shout out to my fellow officers and the executive and all of the past presidents of the association that have been such an inspiration for their guidance and all of their hard work. As mentioned, I've been honored to work with some amazing people in the operating room, on the floor, and in the clinic. And I freely admit that they contribute significantly to the health and success of our patients. I want to thank many of them that are here today: Jenna, Debbie, Ken, Kate, Michelle, Carrie, you know who you are. And those who couldn't be here, they're probably actually looking after my patients right now. I've been incredibly privileged to be part of two amazing groups of surgeons in Toronto and at the Mayo Clinic. I want to thank you, each and every one of you, for educating and supporting and challenging me throughout my career. I have been, as you can see, truly fortunate and blessed in so many ways. My career has benefited from tremendous and gracious membership from so many people. I just can't fit them all in a slide, so I apologize if your picture doesn't appear here. But they've had a profound effect on me, and I am profoundly grateful. And finally, I want to thank my family. Family is not an important thing, it's everything. Family is the compass that guides us. They are the inspiration to reach great heights and our comfort when we falter. I have been so fortunate and lucky in this world, but it is my family that I'm most grateful for. They have tolerated me coming to this meeting, sometimes interrupting March break, and they understood the demands that our profession places on us emotionally, physically, and from a time perspective. My son Christian is here today, and his brother Owen is studying for exams. I love you both, and I'm so proud of you. Finally, I want to thank you, the membership at the AHPBA, for allowing me this great honor of the presidency for the past year and the opportunity to address you all. The future of this organization is incredibly bright. I took these pictures this morning on my run, and it just reminded me that this is the dawn of a new era for this association. This has truly been a privilege and one of the highlights of my professional career. Thank you so much for this honor.